First of all, I would like to welcome all our speakers for tonight and our audience. And I would like to thank Saudi Heart Association and Medtronic Company to put people together, our eminent speakers, international speaker, and our Middle Eastern speaker. And I think the subject is very interesting for most of us, either in intervention, in nephrology, or in cardiology in general. And our subject tonight going to be hypertension management in 2021, renal denervation as a complementary treatment in addition to lifestyle and pharmacology treatment. We'll try to touch on the prevalence and adherence in our region for the hypertensive patient. We know that hypertension is a global crisis. Hypertension remains as a leading preventable cause for heart attack, stroke, death. As we know, more than 50% of patients, unfortunately, they are on a good medication, but the control is not good. The medication or adherence to the medication is a big problem everywhere, including our areas. People, most of the time, they are not having good compliance, or they don't like to take a daily medication. Renal denervation could help to address unmet need as adjunctive approach to lower the blood pressure. And as we can see here, hypertension prevalence by world region in 2010, we are one of the major areas where we have a lot of hypertensive, and the prevalence here in the country of Middle East, especially Saudi and Gulf, it range between 28 to 29, both in men and women. Hypertension remains the leading global risk factor for death. As you can see here, it's number one as a risk factor for death. The causes of death worldwide attributed to increased systolic pressure more than 140, and we face it as interventional and cardiologists. As you can see here, ischemic heart disease is the highest. Then our neurologists, they see more ischemic stroke and hemorrhagic stroke. Also the nephrologists, they see more chronic kidney disease due to high blood pressure. The global death rate attributable to high systolic pressure in this paper compare 1990 to 2016, there was increase in the ischemic heart disease and stroke between the 1990 and 2016 in spite of good medication and more awareness of the patient. Globally, you can see the death rate attributed to high systolic blood pressure according to the countries, and China was one of the highest countries of number of deaths due to high systolic pressure. India was the second, Russia was the third, United States was the fourth. The hypertension control in high income and low income and middle income countries, comparing to 2000 and 2010, there was more problems or uncontrol of high blood pressure, especially in the low and intermediate income group in comparison with high income group. This could be due to high salt intake and low potassium, less activity, overweight in those low income groups. And unfortunately, in spite of lifelong polypharmacy, good medication is still, as you can see from this graph, that US hypertension prevalence remains steady in spite of all those medication and advancement in pharmacology. And again, you can see more mortality in USA in the rural area in comparison with the urban areas. And we know about the change of the guidelines in 2017, especially the American, and this lead to more incidence or increased incidence of hypertension or more patient and at the same time, more aggressive treatment if you combine those two guidelines. We know that reduction of systolic or office systolic blood pressure are associated with clinical reduction. From the meta-analysis of those 123 hypertension trials, there was a reduction in major cardiovascular events, coronary heart disease, stroke, heart failure, renal failure, all cause mortality. If you treat the patient, this will reduce the event. Do we have any data from Saudi Arabia? Yes, there is some papers published. This is one of the recent papers showing the hypertension screening and prevalence and awareness in Saudi Arabia, a cross-sectional study done by colleagues, Al-Ghamdi and his group, where they study about 1,000 patients, and the result that out of total patients participate in this study, more than half were males, like 57%, and most of them, 81%, resided in urban areas. And there was a higher prevalence of hypertension among males was reported, who were unfortunately young adult, less than 35 years old, and having normal body mass index, and were urban resident. The awareness level was higher among males and rural participants. And as you can see from this graph, there was the awareness was more in the male patient. And again, the awareness was more, which is surprisingly in the rural patient, although the number was small. Another national survey was done in 2013. Hypertension was associated with risk factors in the Kingdom of Saudi Arabia, and they found that 15% and 40% of Saudi were hypertensive or borderline hypertensive, respectively. And the risk of hypertension increased among the men and increased with age, overweight, diabetes. We have a very high incidence of diabetes in our country, around 29 to 30%, and also associated with hypercholesterolemia. 58% of hypertensive Saudi were unfortunately undiagnosed in this study, and these were more likely to be male, older, and diagnosed with diabetes. And as you can see here, undiagnosed patient, men up to 60% of those patients included in that survey, they were undiagnosed and uncontrolled between 19 to 21. And their conclusion that from this study, along with those we reported previously in the TBD to 2010, call for a national plan to prevent and control the burden of hypertension in Saudi Arabia. Indeed, the plan has to be comprehensive to include programs to improve health behavior such as diet, which is very important in this society, physical activity, and thank God you see a lot of people now doing a lot of exercise. There's a lot of campaign, which is excellent nowadays. Moreover, the plan should increase healthcare utilization for preventive services, as uncontrolled blood pressure leads to catastrophic events, as we know, such as a stroke, heart attack, and renal failure. Physicians in the Kingdom of Saudi Arabia should be encouraged to monitor their patients to ensure that their blood pressure is controlled. Saudis should be encouraged to monitor their own blood pressure and seek medical care to control their condition. Thank you very much. And I think with this, we will move to have more updated data and evidence. And the next speaker will be our guest from Germany, Dr. Felix Mafford.
Thank you very much, Dr. Mohammed. Good evening, everybody. It's a real pleasure to join you, at least virtually here from cold Germany to Saudi Arabia and to any country we are listening from. My name is Felix Mafford. I'm working as an interventional cardiologist, but also as a hypertension expert here in Germany. And my task now is to update you on renal denervation study data. 2017, 2018, and 2019 were very important years for renal denervation. And in the next couple of minutes, I will try to summarize the most important evidence that you need to know for clinical practice and where we are moving to. Well, I think everybody knows Symplicity HTN-3, which was the third trial of renal denervation and the first sham-controlled study conducted in the United States, where a monoelectrode catheter was utilized in patients with very severe resistant hypertension. And that study failed to prove superiority of renal denervation as compared to sham treatment and blood pressure lowering, but confirmed the safety. And this trial is probably a landscape trial, because in the aftermath of that study, there were only two options, I think. One, to let renal denervation rest in peace, or to understand the confounding factors that probably influenced the trial's outcome. And that is what we did. So international groups convened, tried to understand what happened in HTN-3, because the evidence, the preclinical evidence and prior evidence to HTN-3 was so solid that we felt it would be inappropriate to disprove the renal denervation indeed works in patients with hypertension. So a set of new trials were designed, very meticulously conducted around the globe. And some of these studies are now completed, including the first pivotal trial. And I will summarize now the most important outcomes of these studies. You can see here the full flag clinical trial program that has been developed by Medtronic. Over 4,000 patients have been studied now across multiple trials, randomized sham-controlled trials, but also registries. And this is an important data source now, because we are seeing in real-world patients that denervation indeed lowers blood pressure as well. And you can see on the right-hand side that we're looking also into new indications such as atrial fibrillation, but also addressing unmet needs such as patient preference. And I'm sure Professor Roland Schmieder will discuss that with you as well. So what do we have now to discuss? Very importantly, the Ofmet pivotal trial, where denervation was investigated in patients without any concomitant antihypertensive medication. And that is important to understand. So what we did here is we compared the device for the first time to an antihypertensive compound. And if you would investigate an antihypertensive compound for the first time, you would study this in a patient population that is not receiving any concomitant antihypertensive medication. And that was exactly what we did in the Ofmet studies. Clinically, probably more important is the Unmet experience, where denervation was studied in patients with medication. And on the right-hand side, you can see here the global Symplicity registry, which I will also present, where you can see that denervation, even in the long term, lowers blood pressure quite efficaciously in patients with uncontrolled hypertension. So let's go into medias res and start with the Ofmet pivotal trial. As said, it's the first pivotal study in renal denervation. You can see that we included patients with an uncontrolled blood pressure on several visits. They were coming to the hospitals, where we also utilized drug testing to make sure that the patients were really off antihypertensive medication. Again, no concomitant drugs were prescribed, and the patients were then randomized to receive either an invasive placebo, a sham control, or renal denervation. Again, patients did not receive any medication, and we collected the primary endpoint, which was a powered endpoint for ambulatory blood pressure, but also office blood pressure change at 3 months of follow-up. Thereafter, the medication was up-titrated in case the patients were not controlled to society recommended blood pressure targets. High-level summary of the results. What you can see here on the left-hand side is the 24-hour systolic and diastolic blood pressure change in dark blue, significant falls observed in renal denervation. And from a clinical trialist perspective, even more important, I have to admit, is to see that there was no sham effect in these studies. And this is very different compared to Symplicity HDN3, where we saw a huge fall in blood pressure. Here in these studies, where we addressed almost all confounding factors, you can nicely see that there was no significant blood pressure change in patients treated with sham. And on the right-hand side, the office blood pressure fall in magnitude larger than the 24-hour systolic blood pressure and diastolic blood pressure, which was of course expected, but we see blood pressure changes that range somewhere in between 9/5 millimeters of mercury in office systolic blood pressure. Is that meaningful? And you have seen that slide in a different fashion by Dr. Mohammed already. We know from meta-analysis that indeed blood pressure lowering is proportional and is associated with improvements in outcome, and even modest falls in blood pressure translate into significant improvements in outcomes, morbidity and mortality reductions. You can see that a 10 millimeter drop in office systolic blood pressure in a meta-analytical fashion reduced relative risk for stroke by more than 25%, heart failure more than 25%, ischemic heart disease 15%, and death 13%. So significant in terms of the improvement on a patient level, even with modest blood pressure falls. But this is something we have to keep in mind when interpreting the results that I just presented. What is also interesting, and we are getting more and more insights into the blood pressure lowering of renal denervation, which is shown here. And it's quite interesting to see that denervation appears to elicit an always-on effect on 24-hour blood pressure. What you can see on the left-hand side is the denervation group, on the right-hand side, the sham group, a dark blue baseline, light blue 3 months of follow-up. And when you compare the renal denervation group to the sham group, you can see that the denervation group had a significantly lower blood pressure at 3 months follow-up, and particularly the morning blood pressure, the nighttime and early morning blood pressure was significantly reduced as shown here. And this blood pressure is particularly relevant because it has been associated with an increased risk of stroke. So an always-on effect that is not depending on trough and peak measures as seen with antihypertensive medication, but appears to be always on, which is a unique feature of this device-based approach. Next study, as said, clinically more relevant, the on-medication experience probably, because here the denervation was combined with antihypertensive medication, but in a different fashion, not as done in HDN3, where patients received 5, 6, 7, 8 antihypertensive drugs. In this trial, we restricted it to 1, 2, or 3 drugs. And in this study, at 6 months follow-up, very consistently, as compared to other studies, significant reductions in 24-hour systolic blood pressure, in 24-hour diastolic blood pressure, 9/6 millimeters of mercury, and office comparably reduced 9.4/5.2. So we have now quite solid evidence indicating that denervation also works in patients who receive commonly used antihypertensive medication, and that was the objective of the SPIRAL Unmet trial. If you compare now here all study data and summarize all study data that is available, I think you can check the box and clearly state that denervation proved its efficacy. It's lowering blood pressure. It can lower blood pressure in patients with uncontrolled hypertension. And we have the evidence now, not only derived from the SPIRAL trials, but also from the RADIANCE study, which utilized a different catheter, but obviously showed a kind of class effect. So we have 4 independently designed, independently powered studies that all confirm the blood pressure lowering efficacy of renal denervation. So I think that box can be checked now. Lastly, I want to discuss with you the global Symplicity registry. And this was conducted and started to enroll patients in 2011 already. And it will include up to 3,000 consecutive patients with uncontrolled hypertension. So it represents the largest cohort of patients, the largest database that is available. We have almost 2,800 patients enrolled, And we also see patients for long-term follow-up up to 3 years. And this is becoming an increasingly important database, not only because of the size, but also because of the long-term follow-up that is available within this study. When you now look, and this is a quite busy slide, I apologize, I just want to highlight the patient characteristics here, few aspects. So in a real world situation, it's interesting to see that the investigators obviously decided to include patients with severe hypertension, 60 years of age, history of cardiac disease, and almost 50%, 40% of the patients were diabetics. Every fifth patient had an impaired renal function, and blood pressure was quite elevated, 166 in office, 154 in 24-hour, and almost five antihypertensive drugs were prescribed on average, and a pretty high ASCVD risk score was observed. When you perform renal denervation in that real world setting, you can lower blood pressure, and that blood pressure lowering is of course higher than what we see in sham controlled studies, in these artificially controlled studies that I just presented to you. Here we see blood pressure falls that range somewhere in between 13 to 17 millimeters of mercury for office and 7 to 9 millimeters for ambulatory blood pressure. If you then look into patients with the so-called resistant hypertension cohort, the patients that we included in the Simplicity trials, you can see that the blood pressure fall is even greater, which is related to a well-known phenomenon. The higher the baseline blood pressure is, the greater is the fall. But many physicians and colleagues ask very often, why is the blood pressure fall in the sham-controlled studies smaller? Obviously, because it's sham-controlled first, but also because it's a different patient population. If you denervate patients with severe resistant hypertension, as shown here, you can see larger falls in blood pressure that range somewhere in between 20 to 23 in office and 8/10 in 24-hour blood pressure. We looked into various subgroups, isolated systolic hypertension versus non-isolated systolic hypertension. There was no significant effect in this larger cohort. Atrial fibrillation, and quite interesting subgroup because of an increased risk of stroke, of course, relevant falls in blood pressure observed in patients with AF as well, and no change in antihypertensive medication classes that were utilized. So the fall in blood pressure was independent of the number of antihypertensive medications that were prescribed to the patients. Overall, and this is an important slide because it shows that the fall in blood pressure that we observed were not related to an increase in medication. Indeed, the opposite was the case. On average, the number of medication decreased, but importantly, we controlled significantly more patients throughout follow-up, as shown here. At baseline, only 13% of the patients had a baseline blood pressure below 140, and that increased by almost 3 times at 3 years of follow-up. eGFR remained stable in those patients. There was no clinically meaningful fall observed in those patients. And even in high-risk individuals, and this is my last slide, even in high-risk individuals, we appreciated significant office and 24-hour blood pressure reductions from 3 months up to 3 years in almost all subgroups, including elderly patients, patients with atrial fibrillations, high cardiovascular risk, diabetes, and those with resistant hypertension. With that, my dear colleagues and friends, I'd like to thank you for listening. Just to summarize, I think we have built the proof of concept for the blood pressure lowering efficacy of renal denervation in the Ofmet, but also the Unmet sham controlled trials. So we know that denervation works whenever it's being done right. And the GSR study showed clinically meaningful and statistically significant blood pressure reductions that sustained throughout 3 years of follow-up, demonstrating the durability of renal denervation. Thanks again for listening.
Thank you very much, Dr. Felix. It was a great talk and overview about the evidence we have nowadays about renal denervation. We're going to move to our next speaker, Dr. Ahmed Imam from Kuwait, and he will talk to us about the hypertension clinic and RDN experience in Kuwait from Chest Hospital. Dr. Ahmed.
Assalamu alaikum. Thank you, Dr. Muhammad, and good evening, my dear friends and colleagues. It's my pleasure to be here today and be part of this hypertension live webinar on the management of hypertension. And thank you, of course, for the invitation. I'll start. Okay. I'll start with a brief introduction. Then I'll speak a little about our hypertension program at the Chest Disease Hospital. Then I'll speak regarding our RD experience and what data we have. Then I'll end by case presentation, and then I will conclude. So a small briefing about our Chest Disease Hospital. It's the first and the largest tertiary cardiac center here in Kuwait. It has been providing the care since 1959. It's composed from 4 departments, adult cardiology and cardiothoracic surgery, pediatric cardiology and cardiothoracic also. The hospital has like 230 bed capacity, and it's follow like more than 200,000 patients annually in our OPD. We have 7 cath labs, 3 OR, hybrid cath lab, 2 ICU, and 1 CCU in our hospital. Sorry for that. We like do like 7,000 coronary angio per year and 3,000 PCI per year. We have a TAVI program also like 150 per year. Mitral clip, mitral valvuloplasty, and septal ablation is also among our procedures. So the renal denervation therapy program has been started at Chest Disease Hospital in 2013. After the much hope that we have with initial Simplicity 1 and 2 trial with the double digits decrease in the blood pressure at that time. But unfortunately, after the Simplicity Hypertension 3, here we stopped our program, and we wait until the data to be reviewed. So since the publication of Hypertension 3 trials, as said by Dr. Felix in the previous presentation, and due to the introduction of these new trials and new data that shown there is a significant blood pressure reduction after change in the device technologies and improvement of the procedure itself, going away from the only proximal renal artery to more distal segment to be ablated. So this new data actually encouraged us at Chest Disease Hospital to revisit our renal denervation program, and more than that, initiating our resistant hypertension program. So now I'm going to talk about hypertension and renal denervation program at our hospital. We start our program with the hypertension clinic as the core of the program, and we defined our goals to examine, evaluate, and give those patients another treatment options. And as you can see here, we created, this is a referrer sheet from, and we distribute this sheet to our peripheral and to our general cardiology clinics, and we expect from our program to take care of those patients and to give them pharmacological and non-pharmacological measures as well as intervention option for those patients. This is our patient flow chart. It was adapted from the Italian guidelines. Actually, it's an important slide because this is the flow chart and the pathway when we receive the patient at our clinic. So our referred patient will be evaluation in 4 points, as you can see here in this circles. We accurately measure the office and even 24-hour blood pressure of the patient with adjustment of the patient cardiovascular, and can create patient cardiovascular risk assessment. Then we discuss with the patient regarding his drug adherence, and also we screen for the secondary hypertension, and this is usually needs multiple visits before exclusion of the secondary hypertension as a cause of patient hypertension. Then after this investigation and blood pressure drug adjustment, if the blood pressure of the patient is controlled, so it's only his for clinical follow-up and medical treatment. But for those patients not reaching the blood pressure targets and blood pressure is still above limits, we offer renal denervation and we'll discuss with this possible as a possible therapeutic option. We discussed with the patient and we informed him about the risk, about the benefit of the procedure and the realistic possibilities and of success of this blood pressure reduction according to the data that we have till now. Then after this, of course, we ask the patient to sign the consent for the procedure. Each case in our center is discussed by a multidisciplinary team, and after the procedure, the hypertension clinic will be in charge to follow the patients and update the intervention team and the multidisciplinary team about the procedure and planning if there is any future treatment or interventions. So what data we have now in our hospital? Actually, our first patient was enrolled on October 2019. We enrolled till now like 15 patients till date. Last patient was done last week. RDN procedure was stopped 7 months from January due to the COVID-19 pandemic. We restarted again on July 2020. Our main inclusion criteria in this for our patient in this registry, age between 18 and 75 years old, and office blood pressure or 24 systolic pressure more than 150 millimeter mercury. Our main exclusion or major exclusion criteria are secondary hypertension and GFR less than 40 ml per minute. If we look to the data that we have till date, the mean office systolic blood pressure at the baseline, as you can see here in this column, is 174 millimeter mercury. The systolic blood pressure at the baseline was 88 millimeters mercury. This is after 1 month follow-up. So after 1 month from the RDN, the mean office systolic blood pressure is 148, about 26 less than the baseline systolic reading, and also the diastolic blood pressure 1 month after the procedure is reaching 81 millimeter mercury with 7 millimeter mercury less than the baseline diastolic pressure. And more than that, we have like 1 year follow-up for 5 of our patients, and those patients who completed their 1 year follow-up. So at what year after the RDN, we have, of course, same baseline measures, 174 for the systole and 88 for the diastole. But after 1 year, we have the mean follow-up reading. It's for those patients, 151 millimeter mercury, about 23 less than the baseline readings. And for the diastole, actually, it's there is no much change regarding the baseline. Of course, we are waiting for more patients to be enrolled in the study, and we will make more statistics in the future. So what about the safety of the procedure? Fortunately, we don't have till now any safety concern related to the procedure, and the renal function was similar between the baseline and follow-up. And also we have no complication till now, such as renal artery stenosis or renal artery dissection. Now I'm going to discuss with you one clinical case from our hospital with resistant and uncontrolled hypertension with the renal denervation added to the patient as a hypertension therapy. This is a 58 years old male patient, hypertensive for 7 years, obese, diabetic type 2, non-smoker. He had LVH in his echocardiography. Office blood pressure is 165/95. GFR is 64. LDL is around 3, and hemoglobin or glycated hemoglobin is 7%. Patient on beta blocker, RBs, and chlorothiazide, as you can see, diuretics, and also in amlodipine 10 milligram. So we started a procedure. Usually we start our procedure, as you can see here, with aortography, so we can know the takeoff of the renal vessels, and we assess or looking for any possible accessory renal artery. We used the Simplicity spiral catheter. It's a fixed French compatible guide catheter over a 0.14 guide wire. This catheter is used to deliver the radio frequency energy to the renal nerve through the artery wall. We tackled the branches or the vessels range from 3 to 8 millimeters of the main and distal branch, of course outside the renal parenchyma, when the nerves are closer to the vessel wall. And as you can see here, when we retract the guide wire, the Simplicity catheter confirms the site or the shape of the vessel, so it's not closing the blood flow anymore. And this is the generator. It's control the type of and amount of energy that we give to the nerves. We have also the remote control, and this is a buttons. By pressing these buttons, we can select or deselect these electrodes according to the site that we want to ablate. And here, this is for the left renal artery. We are here trying to assess the renal vessels, and branches also range from 3 and 8 millimeters, as I said before, including the main and distal main vessel, and also the branches that we can do, because the more we can ablate, the better result we expect to get. So as we can see here, we're trying to placement of our spiral catheter in various arteries. And of course, we can usually and always we can assess our position by contrast injection. So here you can see the spiral catheter in this branch, and here in the other branch, upper branch. We are trying to ablate every single branch ranging from 3 to 8 millimeters outside the renal parenchyma. Same procedure also for the right kidney. We select the renal artery to the main renal artery, the right one, so we can select and pick up the branches that we need to ablate. Same procedure, we are ablating as we did with the left kidney, trying to go for upper and lower and every branches outside the parenchyma that ranges from 3 to 8 millimeters, as I said before. After our procedure, usually we are taking to control angiography that we can be sure everything is fine with the patient. So in conclusion, there is a space for intervention therapy of the essential hypertension, in addition to the lifestyle and the pharmacotherapy. And due to the review of the technique and the modification on the technique after the hypertension 3 trials, and going for the renal branches other than the main branches. So in the future, we're expecting to have more and more better results. And thank you very much. I hope this has been useful. Thank you.
Thank you very much, Dr. Ahmed. And we're going to move, because of the time, to our last speaker, Dr. Ronald Schmieder, who will talk about patient selection for renal denervation. And Dr. Schmieder, he's a nephrologist from Germany.
Dr. Mohammed, thank you for this invitation. And it's my pleasure now to focus on the patient selection. Actually, the most important point, which are the right patients where we have the greatest benefit in our patients. Now, first, this is my conflict of interest here, but I want to start with a very busy slide and just to focus on one thing which needs to be stressed when we look at the safety, and all these studies that have been discussed so far, there is no safety issue. And having that in mind, we can now open up and say, now, which are the most appropriate patients where renal denervation is the best treatment choice for the hypertensive disease? And I would like to focus on the patient selection and the patient preference. And before going to that perspective, let me discuss one important thing, how we as doctors are used to think in medical terms. And of course, one of the most important questions that came up, which are the best predictors for the blood pressure response after renal denervation? And you can see here a list of baseline characteristics, which have been analyzed in several studies. You see also some procedural aspects that have been analyzed. But taking all together, and it's my view, we can discuss that, of course, but my personal view is what is consistent is that the baseline systolic blood pressure is the most important one and a consistent predictor in several trials. And actually, this is not surprising. Look at this scheme. It comes from a drug study with 2,000 people followed up for several months. The decrease in systolic blood pressure was dependent on the baseline blood pressure. With 180, you have a greater fall than if you start with 150. And Felix Mafford already stressed that point, that we have to take into account the baseline blood pressure when we go to our patients and discuss with them what is the potential fall in blood pressure on average. And this holds true, this relationship, for drug studies, for the use of office or lower part ambulatory blood pressure, but also very nicely in a summarizing analysis of 40 device trials for renal denervation. The higher the baseline systolic blood pressure, the greater was the fall. So having said that, we have to move on and think about the categorization of our hypertensive patients. We know the grading by blood pressure, by office blood pressure, I think I stressed that, and also by comorbidities or other risk factors. And most of the studies started here. Here, when we have resistant hypertension, when we have this kind of patients, which have been also used in the first pilot studies, but now also in the global Sympathetic Registry. And there we see this clear-cut reduction by 20-25 mmHg fall. I actually call them rescue patients because they are usually in clinical practice. You have 7, 8 drugs, blood pressure still 160, and actually you are really hungry to have another option for treating these patients. But I think we have to move more to these patients, grade 1, grade 2 hypertension on no or 1, 2, or 3 antihypertensive drug. That's the majority of the patients. And there, I think renal denervation should have a place in the treatment strategy for these kind of patients. Whether high normal or mild to moderate are ideal candidates, actually, I don't know. But I think we really need to stress that from medical terms, we should have these patients who may have already some reversible organ damage, but where blood pressure decrease has a full effect in terms of repairing the vessels, repairing the heart and kidney damage, and they are preventing cardiovascular events. Now, there has been a survey in physicians that has been carried out in the US, and it turned out that physicians are more likely to recommend renal denervation for patients with higher blood pressure levels and greater number of medication. It's not surprising. That's where renal denervation started to be used first. And here you see some judgment from referring physicians with respect to medication. 0 or 1 means they did not recommend, and 4 and 5 means on a Likert scale they strongly recommend to use renal denervation. And the more medication the patients have, the higher was the feeling of the US doctors to recommend renal denervation. And the higher the blood pressure was, here we're coming again to these kind of resistant hypertensive patients and having a high load of drugs already on board, these were the patients where the physicians feel we need to use renal denervation. With the proceduralist, interventionist, same pattern, no major difference. But this is what just one side of the coin. Let's shift gears and let's go to the patient. What are they thinking about renal denervation? And it's a completely different pattern. In patient research, as illustrated here, they do not think in these medical terms. They don't think about blood pressure grading. What you can see here is acceptance and rejection by patients' willingness to have renal denervation or not. And overall, 47% accepted renal denervation as a treatment option. And this was completely independent from the level of blood pressure the patient had. There must be other factors which determine whether the patient prefer to have a drug therapy or prefer to interventional therapy, such as renal denervation. We did a survey in Germany in more than 1,000 hypertensive patients, patients coming into their primary care physician, and we asked them, well, were you prone and would you prefer renal denervation? And of those patients who are not on any medication, but it was clear hypertension needs to be treated, 38 points said, yes, we are willing to have renal denervation instead of a drug. And in patients where 1 or more medication was prescribed already, 28% still that, yes, we do not want to have an increase of our drug burden, we prefer renal denervation. And we looked at determinants for the preference of renal denervation as a strategy to treat hypertension. There were more males, they were younger who preferred it. And when you look here in the lower part here, more people said, well, we had some side effects. When you ask them, had you had ever side effects? And they say, yes, these were the patients where they had preference for renal denervation. And of course, so side effects is something which patients want to avoid and make them more prone to have renal denervation instead of having another drug combination or whatever the primary care physician would suggest. And likewise, very frankly, when we ask the patients, well, how adherence was in these patients, and those patients who preferred renal denervation, they really admitted, we are not always taking our drugs as the doctor wants to have us. Those there were more non-adherence. And I think this is an important point because it's neglected. Non-adherence is a driving force of uncontrolled hypertension and really is also an expression of the patient preference. Now, this was a very simple question and we applied that. We have now objective ways by looking in the urine and analyzing the urine, whether the drugs has been taken or not. Very sophisticated, very accurate. And this has been carried out in a number of studies in Europe and US. You see here a summarizing analysis with the result that 44% of the patients had not taken the drugs as prescribed. Nearly every second patient does not what we think is best for the patient. And 17% really said have not taken any drug. So they were a total non-adherence. And this is something we have to respect when we talk to our patients and think about how can we treat him best. So to bring these 2 components together, I think on one hand side, we as physicians, we are structuring our decisions according to medical conditions. What is the grading of the blood pressure? How many drugs have we described? What are the comorbidities? How urgent is it that we now need to treat the blood pressure controlled? But on the other hand, we should not forget the patients are thinking differently. there are patients really who prefer to have renal innervation, an interventional procedure, instead of taking a drug. And thus, we need a shared decision-making process to discuss risk and benefits in order to come to a very solid decision. Now, in the guidelines, and this has been already stressed, the Italian Society of Hypertension, they have a very good checkup list before starting to talk to the patients. But it focuses maybe too much actually on resistant hypertensive patients. We should go, as they state, to difficult to treat hypertension or to uncontrolled hypertension. We need a risk assessment. We need to have 24-hour ambulatory blood pressure to rule out white coat hypertension. We should check for drug adherence. And this might be also already an expression what the patient wants to have. And then we have to come to a shared decision-making process with a conclusion, what is the best drug for our patients. Of course, we should rule out secondary causes of hypertension. So a very nice scheme for a clinical pathway to set up a clinical program for renal innervation. The Taiwan Hypertension Society, combined with the Taiwan Society of Cardiology, had a similar consensus statement. And I want to stress just here, not to repeat all things, but to say non-adherence was one of the major factors that needs to be respected, because here we come to patient preference. And also, we have some patients who are simply intolerant to medication, or they say they cannot tolerate it. But again, it's an expression of the preference, what the patient wants. So my personal view for the years, for the upcoming years, how we have to treat our hypertensive patients, we have lifestyle changes. Nothing really has changed when you look at the guidelines of the last 10, 15 years. We have now drug combination, single pill combinations are of great help. But I think also we should have, and we will have in the near future, in clinical practice, interventions. Renal innervation is the most advanced and maybe the most suitable, which we can use in a broader field for our hypertensive patients. Now, having said that, I want at the end, and we can discuss it later on, just to show you one patient who maybe think, should I choose renal innervation or not? And this patient is a director, very busy job, was diagnosed with hypertension 5 years ago, 50 years old, male subject. And when we ask him about adherence, he says, yes, well, sometimes yes, but it's variable. I don't have always the time to take the drugs, and sometimes I forget. So from his medical history, nothing really sensational. With respect to his blood pressure, 159/93, well, for sure not controlled. Confirmed by ambulatory blood pressure, 149/82. And with respect to his lab results, no diabetes, cholesterol, well, clearly too high. And with the drug therapy, 2 drugs, but obviously he is not totally adherent to that drug combination. So the question we have to discuss here, is this a patient for renal innervation? Maybe you think, yes, great, that should be. Or only if we are sure that he is a non-adherent patient, we have to verify that. Do we know the preference of the patients? We need to respect that. Or you say, well, I use a single pill combination with 3 drugs as an alternative, or maybe other options. Let's discuss that throughout the next minutes. Thank you very much for listening.
Thank you very much, Dr. Schmieder. And what you did a great job for us and telling us how to select those patients. And I think the floor is open for discussion, and we can use this case you presented for us as a good case to discuss. But before we go to your case, there was a burning question from one of our colleagues. Is there any chemical markers to measure if you perform adequate ablation? And what is the average of contrast procedure? That's what we want to know from the expert people. Felix, what do you think? Is there any markers? Can tell us about the success of our intervention.
So we have to distinguish between 2 things here. One is, can we use a marker to identify patients with a high likelihood of response? And here The answer would be probably. So we do see a signal in a renin activity. So indeed, patients with a very high renin activity were those responding best in some of the studies. And that's question number one. And question number two, intra-procedurally, there's unfortunately no marker established yet that can help us to tell at the end of the procedure whether we have completed our job and denervated the kidney completely. We're working on flow measurements, we're working on resistance measurements, but none of these markers made it to clinical practice yet.
And also we would like to thank the attendee. You know, we got more than, almost we are approaching 600 people attending this session, which is
great.
That tell you how people are interested, to be honest with you. Dr. Hani Raghi from Egypt. I mean, you started the program maybe a few years ago. What is your input with that case? Patient the 50 on 2 medication only. This is a very common scenario, you see.
Thank you very much, Dr. Mohammed. I really enjoyed this, and I had actually attended this in meetings, but it was still very educational. I learned a lot today. Very quickly, I would like to say one thing. After the doubts on the whole of renal denervation by Simplicity 3, which had we had major reservations about, those of us who had already worked and had seen the procedure work, it was very nice to get definitive proof that this is something that works. So I'm going to talk about the case that Roland just showed. If you, as an audience, as one of our 600 audience today, do not believe that renal denervation works, then you might as well switch off. I mean, you don't need to even look at it. But if you believe that renal denervation works, but you want to know how to use it, let me tell you my own reflection about this. The first thing is, please consider it like a pill, like a tablet that you take only once in your life, and that brings your risk down by a certain number of millimeters of mercury. That makes your blood pressure easier to manage, that reduces your stroke risk, that reduces your dialysis risk, that reduces your acute myocardial infarction risk, that will probably make you take less pills, maybe, and will make your blood pressure easier to control. So you can look at Roland's case, and the first thing you might say, why is he just taking telmisartan 40 milligrams? What's this dose? Why not give him an 80 milligram over 10 amlodipine? You can do that. Go ahead and do it, you know. But performing renal denervation for this patient is like giving, like I said, like giving a potent pill, which is going to work forever. I mean, there are no other things I'm aware of in medicine which are like that. If I was a diabetic patient and I could undergo a procedure which would make me take less medicines, have my diabetes easier control, I would go ahead and do it. And I think the resistance we're seeing from various multiple specialties is actually very healthy, because it's proof of the skepticism of the medical community and how they want absolute proof. But we have to be very careful not to cross the border, which can actually deny really good benefits to our patients. So my answer to Professor Roland's case would be, I would probably personally take this patient to 80 milligram over 10 or 80 over 5, where there are no side effects, and try him for another month, and just 1 month. I won't wait forever. And if I don't reach the target, and if it's uncomfortable, I would definitely offer him renal denervation. That would be my
Dr. Majid, what do you think? Thanks.
Yeah, and I think we need, in the case that the tolerance and the compliance needs to be more defined. And I think, if you can reach a conclusion of an issue with the, with the compliance, then, I mean, this patient is young. So, I would consider that he goes for an RDN, because, you may be able to, to adjust the treatment, but still the issue of the compliance is going to be there. So if, that, I would address that And if, you know, if I reach a conclusion that this is going to be an ongoing problem for him, then I think, you know, the procedure would be appropriate for him.
Dr. Khalid Al-Marri, if this patient in Kuwait?
Yeah, I may be having different idea here.
Okay.
It's basic. I want to talk about two things. We know this intervention, it works. It lowers the pressure. The one thing that I want to stress on, we have to get this treatment to patients or get the patient to the treatment. So one way to do it is to have doctors' awareness. So you can't imagine how many doctors are illiterate about this treatment, and it is available. So you have to go and outreach to the other centers. This is regarding this. We have to aware the doctors, the treatment is available, it works. But to kill or harm any new intervention, to expand the indication quickly. And we have some evidence in interventional cardiology without mentioning the names. So I think if we start to expand the indication of RDN widely and quickly, we may harm this beautiful intervention. If we go to patient's preference, patient doesn't want to take tablets. Every single patient you see in the clinic, the first thing, do I have to take tablet? So I think especially we have enough people who are hypertensive and resistant, quote unquote, whether they are not compliant or they are really resistant. So we have enough patients to use this technology in this group of patients. I don't lean or I don't agree with expanding the indication to patients' preference at this time. So this patient, I would really stress on compliance. If he's not compliant, yes, I would go with RDN. But simple patient preference is not enough to RDN.
Thank you. Dr. Walid Al-Habib, can you unmute yourself? First of all, I think because why I'm choosing Walid now, kept him the last, because he's not interventionist.
Exactly.
That's why I need his opinion.
I'm not an interventionist,
But you like intervention. I know that from my heart.
Well, I like interventionists, but I don't probably like interventionists. Yeah, I'm more of a conservative person when it comes to management. I'm a heart failure doctor, so I depend a lot on medications. And we've seen lots, as Dr. Khalid said, lots of procedures that have picked up very fast, and then we figured out that it didn't make any difference compared to others. Now, the new data here is very promising and encouraging to look into this. But I would want to touch on one point, is that sometimes the choice of medications also dictates how the patients respond to it, even especially when the patients see that their blood pressure is not even changing, taking their medications very well. And one concept that, because of the guidelines that have been changing in hypertension management, one of the concepts that we're forgetting sometimes is sympathetic overdrive. Many of our younger patients, very active, very stressed, work life style, obese or metabolic syndrome, smokers, many of these patients have a sympathetic overdrive that drives their hypertension. And I know that many people are not big fans of starting beta blockers on patients, but I've been seeing it a lot. Just a beta blocker sometimes is enough to control the blood pressure more than the combination that we're putting of 2, 3 just vasodilators that are tackling the same or targeting the same effect. Not to say that this is not a promising and encouraging procedure. I think yes, if the patient is not controlled on several medications, I would really encourage to have it.
Beautiful. Now we're going to go back to Prof. Schmieder from Germany, and he should tell us what he did to that patient.
Yeah. Well, we talked to the patient that you have two choices. Your blood pressure is too high. You are well educated. You understand what high blood pressure means. Yes, he said. and you try to be adherent. Yes, but my circumstances of my daily life are sometimes complicated. So I tried my best. And I said, well, you have two choices. We go for a triple combination in a one tablet. This is one choice you have, and it's really talked about the choice as a preference, or you prefer renal innovation. Well, how long is it on the market? I said, well, I have experienced more than 10 years. It is safe. How good the blood pressure response in your case is different to foresee. So it is an open question. And then we discussed it several times, and then came the question, what would I do? And I said, if I would have your blood pressure, I want to have it fixed and to have it done once an intervention. And then, because I know if I'm getting older, my blood pressure will rise anyway, then I have maybe to rely again on drugs or so. So that was a discussion, but we were open to discuss it with the patient and offered him two choices. And I think the recommend, or one of the comments was to say, why not taking a, let's say, a triple combination for 1 month or 2 months, nothing will happen within this period. And if you are not controlled, we are talking about 130 over 80 in that patient. 130 over 18 is a 156. So 25 down. It's most unlikely that we can achieve that by a drug combination. So actually, at the end, I think he needs both. It's still an ongoing process.
Thank you very much. Interesting question. Somebody is asking, should we involve the nephrologist in this filtration of those patients? And I want you to answer it because you are the nephrologist.
Yeah. Well, of course, with that patient, we did ruling out secondary causes. We looked at the kidney precisely. We did look at renal artery stenosis and rule that out. This was our, let's say, basic work we have to do before. I think this has been stressed in the guidelines by the speakers. I think to come to a good judgment, someone who is a hypertension specialist, irrespective whether it's cardiologist or nephrologist, needs to be involved in that decision.
Excellent. And maybe the last question to Dr. Felix Mafford. I choose you and your name for this session because we know each other and I know you are expert in this field. In the same time, I tried my best to get the expert people in the field, in addition to the heart failure guy. What is your advice? Give us like a take-home message tonight. Is the technique is different now? Is the technology is different? I tried it myself. I like it. But again, we have to choose the right patient. Give us some take-home message for tonight.
So thank you very much. My take-home from this session would be that I think we have, for this interventional technology now, really a proof of evidence, a proof of concept that whenever you interfere with the sympathetic nervous system at the level of the kidneys appropriately, you can reduce blood pressure. And you all, as interventional cardiologists, know well that we have very few interventions that have beaten sham in a controlled fashion. So sham is a very tough comparator, but all the trials are very consistent and indicating that denervation was superior in blood pressure lowering effects and efficacy compared to sham treatment. So that box checked. Then it comes to patient preference, patient selection, and I agree with what has been said. I would also not expand the indication too quickly and too widely. Stick to the high-risk individuals, probably those with hypertension-mediated organ damage, at high cardiovascular risk, patients with diabetes. There are a lot of patients suffering from diabetes, especially in the Middle East region. I know that very well. Patients with uncontrolled blood pressure, chronic kidney disease, so slight impairment of renal function, atrial fibrillation. So the bag of patients at high cardiovascular risk are those that I think are the most appropriate candidates. But on the other hand, don't extend it too far. So don't try to treat patients at the very end stage of their disease, like super severe hypertensive individuals on 7, 8, 9, 10 drugs where nothing works. So somewhere in between, that is where I would identify patients with the highest likelihood of response. And then in the near future, we will see this device and this technology being investigated in other indications, atrial fibrillation, heart failure, chronic kidney disease. And for me, myself, I think these novel indications are as exciting as what we have learned about hypertension.
Great. Thank you very much, Felix. And I think on behalf of the audience and on behalf of Saudi Heart Association, I would like to thank you all, especially our colleagues from Germany. And it was a pleasure for us to have two of our society president on this session, and our brother and colleagues from Egypt, Hani Ragi, our colleague and brother, Dr. Khalid Marri, and Dr. Ahmed from Kuwait. Thank you very much for the audience and for the speaker, and have a good night. Thanks, guys.